Welcome back to Toledo Clinic TV. My guest for this segment is Dr. Robert Hartwig. He is an orthopedic surgeon, and you specialize in hands.
Correct. Wrists and elbows.
Hands, wrists, and elbows, which makes sense since
Right.
they're all connected. Carpal tunnel syndrome has become more and more common as Americans spend more and more time sitting in front of their computers. So you have put together a slide for us to take a look at about what some of the symptoms of carpal tunnel are and what causes it. So if we can go ahead and take a look at that, what causes carpal tunnel?
Carpal tunnel is due to swelling around the tendons as they pass through a confined area in the wrist. The structure that is most involved is the median nerve. Now, the median nerve supplies sensation to the thumb, index, long finger, and half of the ring finger, and can also, with time, produce weakness in gripping, such as holding a pen or a pencil, and just generalized manipulating fine or small objects. Classically, the symptoms, and they can come from a variety of reasons, which we'll discuss, usually will start to wake the patient up at night. And they may not be able to relate this to an activity. Sometimes they can. And the night symptoms often are a classic finding. It's an early finding, and that will often cause the patient to seek medical help. If they're not sleeping, they want to find out what's going on. That can extend to other activities during the day, such as driving for a prolonged period of time when the patient's hand is on a steering wheel. Something as simple as reading a newspaper or a magazine, holding it in an upright position. They start to notice the symptoms come on. They will try to alter their position. There's a symptom or a sign called the flick test, in which they will shake their hand to try to wake it up. Sometimes this even necessitates waking up in the middle of the night. And then it'll extend to difficulty manipulating small objects, putting in earrings, fastening buttons, picking a coin off of a hard surface. Anything that requires dexterous movements, buttons often become a problem.
So is this something that happens gradually over time and the symptoms worsen?
For the most part, it is. There are certain conditions which we can discuss that it'll occur acutely, such as after a wrist fracture, exertional activities, someone who's not used to doing repetitive movements. They decide to paint their house, paint their wallpaper, things of that nature, where they're doing a lot of flexion, extension movements of the wrist will precipitate a more acute episode. Generally, it's more gradual in onset.
Okay, and how do you diagnose it?
Well, clinically, examining the patient, there are certain findings. The history is very important. I mean, the patient many times will give a very classic history for it. There are certain provocative tests, tapping over the median nerve at the wrist called the Tunnel sign, in which as you're tapping along the area where the nerve is under maximum compression, they will note an electric-like sensation or a shock going out to the thumb, index, and long finger. Another test is called the Falen's test, named after George Falen, who was a surgeon in Cleveland, in which the patient is asked to lower their wrist, not in a forced position, but just to let it assume a position of slight flexion. You time the onset of their symptoms, so the more rapid the patient notices the numbness and tingling over the median nerve distribution, the more positive the test.
And what are the treatment options? Surgery, I would assume, would be the last resort.
Treatments, yes, as it should be. If the patient is seen early, many times if they're having problems, symptoms just at nighttime, I recommend a night splint, and just to support it during the time that they're symptomatic. Now, many of these patients will notice symptoms during the day with certain activities, such as working on a computer or data entry. If it bothers them doing that activity, but really not other times, I will say, well, wear the splint during the day during those activities, if you can do those activities with a splint on. If that works, then that oftentimes will prolong any further treatment. If the patient comes in and they don't respond initially to the splinting, and if it's early and they aren't some of the longer standing findings noted, a corticosteroid or steroid injection, in addition to the splinting, one along with the other, will often help to shrink down the swelling around the nerve and basically give the nerve more space. There's not a compromise to the blood supply, which really is what happens when the nerve is under pressure. This tight band, the carpal ligament, is a compressing force on the nerve, and that segment of the nerve is actually deprived of a blood supply for that segment. and that will produce the symptoms. So if you can do anything to basically increase the capacity of the canal by either decreasing the swelling around the tendons, this lining tissue called the synovium, if that will be successful by conservative means, then we can discuss a surgical treatment if it's not.
And what does that surgery involve?
Surgery involves releasing the ligament, the band over it. And in the diagram, this is a tight band, and if there's some anatomical pictures, we can actually take a look at them.
You can bring those up. There you go.
And this is actually demonstrating the tight ligament that compresses the nerve on the left side. The ligament is intact. You can see the nerve as it passes beneath it. Rather dramatically after it's released, you see the hourglass compression, and oftentimes at the time of surgery, you will see this segment of the nerve which is compressed.
And are there side effects now that if you go in and you cut that ligament?
Right.
Mobility problems after that?
Mobility is not an issue. There may be some weakness, as you would expect after any surgical procedure. This tends to, with time, correct itself.
Have you begun seeing more carpal tunnel or diagnosing it more often?
Well, I think the incidence has gone up, whether that's related to certain activities that you mentioned, or I think people are more aware of it. I mean, there's a general knowledge that has spread. People will seek treatment earlier. They'll talk to their primary care physicians who are very much attuned to it. They recognize the symptoms, and many times they will make my job easier by already instituting treatment. Some of them will even inject the carpal tunnel, and if the patient doesn't respond, well, then they're referred. Another study which is diagnostic, and probably one of the best studies, is an EMG or nerve conduction study. Now, that's an electrophysiologic test which accurately measures compression on the nerve. That's done by another specialist, neurologist or physiatrist, who will specialize in that area.
Okay, very good information. Thank you, doctor, so
You
much
bet.
for being with us. We'll be right back.